the cloud. So we are going to talk today about the importance of physical therapy before the surgery. Once we have discussed and when we have recognized the surgery is indicated. Obviously, it makes sense that before we set up the patient for the surgery, in most of the cases, physical therapy is a necessity. We talked about the multidimensional protocol. On top of the multidimensional protocol, if you remember, there are some criteria that we bypass everything, we directly go to OR. That is less than 3 to 5% of the case, like somebody with cardiac syndrome, somebody after with instability, they're not going to get physical therapy. They're going to get to surgery. If we can find out that the reason they have those symptoms is organic, like fractured bone, large disc herniation that requires us to compress the nerves right away. Like last week, I had a 16-year-old girl in the ER who had a large disc herniation. She had a BMI of 53, so nobody really wanted to touch her. She came to us, and she barely, had any sensation in certain areas. And then after the clinic, they called me that she cannot feel the bladder anymore. She cannot feel that she has to go. It's a definition of cardiac or part of a complex system. Those people literally bypass everything, go to the surgery, but that is less than 3 to 5% of the case. The vast majority of the cases, first, you guys do your job, your magic. Then once you give me some letters, some indication that you are stalling, you cannot really do anymore, then surgery becomes an option. But once we decide surgery is an option, that patient is not done with you yet. Now, let's just go into, there's 3 of us, let's have a conversation. When I send a patient to you, Cole, after we set up the patient already for the surgery, we had discussed, we created a protocol together. What are the areas that you concentrate at the moment that I say this patient is going to get the surgery? Here you are, prepare the patient for the surgery. Where do you concentrate your effort at that point?
The biggest thing is educating them thoroughly on the protocol that we discussed. We print it out for them, we email it to them, and just heavily have them understand what their body's about to go through and how to protect their spine post-operatively in order to follow those restrictions and guidelines as best as they can. But also it's so important that they understand what their body is going to go through and experience, that some stiffness, some soreness, some continued, symptoms into their lower extremities. That's still normal post-operatively, and going in with those expectations, letting them know that, you said about 10 to 50%, like we'll have nerve root irritation from the surgery itself that will help, most of the time resolve itself. That's helped significantly when I come back and see them after surgery. So that's a big thing. Then, there are, I feel with such a high population that I treat, I do feel that at least to some degree, I'm able to help them with pain management or building up their activity tolerance, and making sure that they're safe with their ADLs, their transitions, and so forth. So pain management definitely is a big part of what I do as well. But the biggest thing is improving their expectations.
Yeah, well, let's categorize them. You said it as well. First of all, education, then expectation management. But we have 2 other areas that I think are important for the things you do. And to understand that, I want to share my screen here and show you, especially for our surgery, our minimal invasive surgery is important, is this picture here. Let me share it with you. you see all the musculature of the spine. So these are all the muscle that I don't detach, I don't cut. Hey, as you know, when you do a regular surgery, it doesn't matter whatever work you do, you make beautiful paraspinal muscle, and we cut them, we make them into scar here. That's how a scar looks like in real. And that is how a scar look like. Look at the white here. That is scar, that's not muscle. This is muscle. Look at green here is muscle. Red here is the scar. You cannot really, doesn't matter if you make them stronger, we do a regular surgery, they are turned into scar, all your good work is gone. In our surgery, this is traditional surgery on the left, this is our surgery on the right. Those muscles are important, they are alive. And one of the things we like you to do is strengthen those muscles, because after the surgery, a well-vascularized muscle give more protection to the spine. Additionally, we talked about that before. The vascularization of the bone is through surrounding muscle. You build a beautiful, strong vascularized muscle, and which we preserve. That increases the vascularization actually of the bone, and that all return to us as an overall better outcome of the patient. Now, having said that, with all the work that we are doing, this is just around the muscle. What is the hallmark of a patient who has been in pain for many, many years? And literally, this patient have not been able to walk and has been, what is the hallmark of all of them altogether? What is special about them? These patients have not been really able to use their muscles, their functional capacity goes down, right?
Yeah.
Yes, the surgery is never a singular thing that we will only work on their spine. It is their heart, it is their lung, it is their, and these are not just, some theoretical numbers. So somebody who doesn't walk, like you guys have known that when the astronauts come back, they lose 60% of their bone mass. They lose up to 60 to 80%, 70% of their functional capacity of their heart, lung, and so on, because they haven't been using it for like 6 months, a year. These have tremendous impact, not only on the surgery, but even on their preparation for the surgery, on the recovery after the surgery. And that is something all of these patients have in common, that the functional capacity is reduced. Now, I'm going to come back to you, Nick, and tell me, what can you do to increase their muscle mass, not only in the spine, but in the rest of their body, and increase their functional capacity?
Well, I think almost initially, Cole nailed all the educational pieces, and that's great. I mean, that's proven to be very effective because we got to set expectations and make it realistic. But then when we get to the actual, therapeutic intervention piece of what we do, it takes a lot of, I use the word endurance training with these patients. It's not just a singular, power type of training, but more endurance, the ability to, withstand their daily activities. And most of them show up with a lot of faulty movement patterns that have been ingrained. I'm sure you've seen that, Dr. Abbasi, the way that they sit down, the way that they stand back up again, the way they choose to initiate walking. Predominantly it does seem to improve in most patients as they continue to go. So it's building off of those things. I've had a lot of luck more recently over the last couple of years, and almost everybody now has like a Fitbit watch or some type of pedometer. And being able to encourage just a very gradual increase in, tracking their steps every day. And letting them know, even if you have a slight step back on one particular day, they can continue to get back on the horse, so to speak, the very next day and tack on. Maybe it's something very humble, but it's add like 500 steps this day, till you get to that point where you're living in the 6,000 to 10,000 window, because that's proven to be pretty healthy from a cardiovascular standpoint. And then I guess more specific, more specialized to the spine is, some more localized, everybody calls core training, but, training the transversus abdominis, working on some multifidi co-contraction, while at the same time really kind of chipping away at those bad movement patterns globally, and then encouraging some education on some better ways to do it. We've gotten away from like perfect body mechanics stuff, but just letting them know, hey, some degree of flexion is going to happen in the spine. We just have to have a strong, resilient spine to be able to, withstand those types of injuries. I think it's getting better. I think a lot of people have previously come in with some lowered expectations, assumptions on therapy not really being effective, but it's changing that paradigm and letting them know, hey, we're not saying you don't necessarily need a surgery, right?
Mhm.
What we're trying to do is improve your preoperative baseline from, let's say, here to up here, because when you come out of that surgery, you're still going to have a drop in function.
Yeah,
But this way, instead of coming all the way back down to zero, you're somewhere a little bit higher.
yeah,
And you'll be positioned well. Yeah.
well said, Nick. And everybody knows how a normal person become an athlete.
Mhm.
But this is on one side of the spectrum. On the other side of the spectrum are people who have not been really doing much because of whatever.
Mhm.
The functional capacity, like literally the volume of the lung, the pumping of the heart, and goes on to the other side. Whereas an athlete can perform more than I. And somebody who hasn't done much, that goes on the other side of the spectrum.
Mhm.
And certainly surgery is a hit, is an injury.
Yeah.
And exactly the way you described that, if you start higher up, when the surgery brings you too much down,
Yeah.
it's still good enough for your body to recover.
Mhm.
So,
Exactly, because as you've said, these people, I'd say the overwhelming majority have been deconditioned for a long time. This has greatly affected their functional capacity. It's not necessarily something that just happened 2 weeks ago, and now it's more emergent. At least in the cases that we see, as you noted.
mhm.
In many cases, they've already had other surgeries as well, right? They've had ones that maybe were effective for a few years, and then they gradually, other dysfunctions occurred. So you're dealing with people who I just saw one in Albert B at our clinic down there last week. And, for example, she can't walk, which is real. Can't walk independently for more than I'd say about 500 meters. She needs to use some type of walking aid, a cart when she's shopping, anything like that, in order to just help stabilize. So those are just some clear-cut examples of why they need, just general conditioning to begin with, and then just try to improve that preoperative as best we can.
So these are actual steps. I sign up the patient for the surgery. I send you back to you, Cole, and you talk about that they will have pain after the surgery. But more importantly, you tell them what activity will make the pain better or worse.
Mhm.
And I think we all talk about the ADL, activity of daily living.
Yep.
Okay? This is to make the patient as fast as we reasonably can independent.
Mhm.
Now, like anything else, you can do it through the things the correct way or the wrong way. And many times, just the knowledge about how to do things, like it starts with easy thing, like, I cannot wipe my butt. I cannot tie my shoes.
Tie my shoes.
These are so trivial. And once you learn that, it makes such a huge impact on patients' actual activity of daily living and level of independency, that sometimes truly they make or break in overall outcome of the patient.
Mhm.
Very easy, like, if they cannot tie their shoes, they cannot go for a walk. And we know all how important walking is, right?
Yeah.
If they bend to do that, wouldn't be unusual at all. They pull the screw out if it's osteoporotic and so on. Maybe not the first time, but if they constantly do that. Now, and those things is best taught to the patient when they are before the surgery. They don't have this additional stress. You know what stress does, right? It reduces our learning capacity, our functional brain capacity. Those things are best taught to the patient before the surgery. And then we talked about literally strengthening their paraspinal muscle, but as well endurance. I love the word that you mentioned. In actuality, Cole, can you describe to me those things we talked about? Activity of daily living, education, strengthening paraspinal muscle, and endurance. What are the actual things that when I send you the patient, how does that session look like? What are those activities? I mean, if you have picture, I'm really would appreciate if you can even share that with us. That what does that look like in reality for people who never done that and just listening to this?
Yeah, so I typically, I do the education typically in sitting, it's most comfortable, but then when we get to some strengthening and some endurance, I like to keep it as functional as possible, right away. I start in supine often, and I do some gluteal sets, usually in hook line, because then we get a little bit more force for the heels, which will get some secondary, activation of the bifidus and paraspinals a little bit more right away. And then I like to go to.
That's called. Lots of people will listen to that they don't do what I and what you are doing.
Mm-hmm.
You say like gluteal activities and so on. Do you mind to describe them a little more, about what that exercise look like when you are doing with the patient?
Yeah, so I like to start, in the supine or hook lying position, and I just have them clench their buttocks as tight as they can. And then there'll be some secondary activation of the lumbar paraspinal muscles. And one exercise I've really liked is I do an alternating heel press in the table right away. So I just have them press, one heel down and then the other in from the hook lying position, just so that they can get a reciprocal movement. As we're always up and, we're reciprocal beings. So I think that's a really good place to start. And then
is that the isometric kind of exercise?
That is more isometric to begin with. And then if as tolerated, depending upon where they're at preoperatively, I can turn it into more of a marching bridge, but it all depends upon their tolerance.
You want to explain what the isometric exercise is and how can help a patient?
Yeah, the isometric exercise is just the exercise that the muscle is contracting, but however, the patient isn't really moving. It's just the muscle contraction itself. So it's a really good base to begin with. It's starting to get those muscles activating. Those muscles are atrophied. They haven't worked for sometimes years properly. So it's just getting them to be able to contract those muscles on cue, and voluntarily just means a lot for those patients. And then once we have a little bit more success with that, I get them in a seated position, and I start working on some hip hinging correctly, and sit to stands, because again, they need to move, they need to bend forward, but they're going to do it with a straight spine, or this is proper of a spine as we can, and we're getting that movement from our hips, our FA joints, and not our lumbar spine.
So Nick, if I may ask you, what exercise would be most suitable, actual exercises for increasing endurance and functional capacity of a patient? What do you do to increase somebody who has barely walking for last 6 months to increase their functional capacity and endurance?
Yeah, I think one of the best places to start, as Cole mentioned, is some hip hinging, improve the mobility at the true, like Cole said, femoral acetabular joint, the FA joint, the true hip. Make sure you're analyzing that bilaterally, and then whether it's hip hinging, or I like going into maybe some shallow, heightened sit to stand work, high repetitions on that. A lot of therapists, we come on, one of the weaknesses that we've had is we get caught in some low dosing. Historically, maybe it's 3 sets of 10, stuff like that. But as I've gotten more comfortable, I guess, over the years, more confident in my approach, it's starting at a higher surface height, but then maybe doing 20 to 25 repetitions and then giving them a break, because it takes, there's a lot of old exercise science studies that prove that it takes actually thousands of repetitions to retrain somebody into a better pattern, right? So it's actually macro dosing these things a little bit higher. And then taking something that's functional, like step up, step downs, working up to staircases, things like that. And at the same time, not only are you rebuilding a pattern, but you're breaking down, we get an opportunity to break down some of those fear avoidance beliefs that they develop over time. We always talk about those. And some people just avoid going up and down stairs because at one point it was very painful and uncomfortable. And then it's just getting them confident in that again.
So Nick, do you go sometimes to gym?
Yeah.
So describe to us what is that high intensity exercise and how it has been found to be very effective in a gym setting, that when you go to gym, do you do high intensity exercises?
Yeah.
So describe to that how it is and why is it effective?
Well, because you're targeting different energy systems within the body, right? We have your muscles have predominantly 3 different energy systems in which they operate with. You got your slow twitch ones. So that's what we were really working on with the endurance piece. And almost all of the paraspinals, those are predominantly slow twitch type of fibers. Well, we also have larger, more bulky, very strong, powerful muscles that are type 2As and type 2Bs, which are referred to as your fast twitch muscle fibers. And it's it's interesting. I was just on a strength and conditioning, TRIA put on this strengthening conference 2 Saturdays ago. And I took that in, and there's some really cool information showing that it's like, what comes first, the chicken or the egg? Well, over time, people have atrophied in their type 2As, type 2Bs. But is that because they no longer are doing activities that keep them stimulated, right? That maintain some hypertrophy in that tissue. And what they're finding is adults in middle life, as they continue to do things like, so a good example of that, Dr. Abbasi, is you're asking like this, let's put a barbell on somebody's back and squat, right? And that's really, really scary to anybody who's had back pain, but retraining them to do it right. If you do that and you change your dosing patterns to accommodate the weight that you're doing, that you're prescribing, obviously you're not doing 25 anymore, you're maybe doing sets of 5. But you are able to build greater strength and greater power back in the gluteal muscles, the quadriceps, the hamstrings, all those great support structures that actually allow people to maintain a higher level of strength and power over life. Now it can be squat, like traditionally anything free weight is very, very good for that. Better for getting more global muscle activation as well. So it's not just so isolated to those target muscles.
So what you described about the high intensity, obviously, and isometric, certainly no matter which muscle you exercise, that muscle, especially if isometric, it actually induces some molecular changes. Those muscles start producing more muscle fibers. Literally those myosin and fibrin and so on, they increase more of the mass. They just become more active. That is the nature of exercise. But there is another path to that, especially with the repetition, and high intensity exercises are exactly that. They cause the catecholamine release. The catecholamine release, the best indication for catecholamine release is your heart rate. So, and that is what you do. If you have your iWatch or something, Apple Watch, you monitor your heart rate and you want to bring your heart rate for a certain period of time to 120. If you're a normal person, you need that exercises go from normal to higher capacity, because those catecholamine release, they tone your muscle in the heart, lung, your thorax muscle. All of that increases. Literally your volume of the air intake increases because your muscle in the lung become stronger and you can keep a breath and so on. Now, this is the spectrum between the normal and an athlete. There is the other side of this. People, for them, 25 isometric motion is for them the high intensity exercise because they haven't done it for years. So, and that is exactly what I'm trying to convey here for people who don't know nothing about that. What you mentioned, that we have to make them as close as normal as we can, and even maybe a little above it, because after the injury of the surgery, and make no mistake, every surgery is an injury, they can use any kind of capacity they can have.
Yeah.
So practically, in a way, you do something that wouldn't be high intensity exercise for you, but for that person, that is exactly what you're doing. Catecholamine release, high intensity exercise for them to increase their capacity. So we covered more or less, those 4 areas why we send the patient to you before the surgery. And all of that is very important. Now, another thing that the fifth that we haven't talked, when we send the patient to you, for some patient, we know they're going to need some aids after the surgery. Start with a walker or other tools. You are best in situation to estimate what kind of help, what kind of additional aid these patients need, and make that recommendation to us. And patients are asking me, do I need a walker? Do I need a crutch? Do I need an elevated bed, elevated seat in the bathroom, and so on? And my answer to them is universally, no, I'm going to send you to somebody who's going to watch you doing certain things, and then tell me what is the best way we can take care of you. And that somebody is you. Now, I don't see the patient, how they do certain activity, but you actually exercise those activity with the patient. Some of that, when the patient come to you, and I'm sure part of your evaluation is you watch them walking, you watch them going stairs up and down, you observe them how to go from one position to another. And I cannot overemphasize how important is those teaching them the correct transitions, because no one is going to always sit or lay down in the bed and so on, but they have to go from one position to another. And I can tell from my own back problem that if you do it the wrong way, it just kills you to go sitting even to standing. But if you do it the correct way with additional knowledge, it makes it so much more bearable. So transition is something that we want them to learn. Now, and how many sessions do you think in average, Cole, a patient needs to go through that process? Because part of this is for us to refine our approach. How many times should I order my pre-op physical therapy? What is you? Obviously, if they come and they do better, you release them sooner. If they come, they need more, you ask them to come more. But in average, what do you think?
Well, I think at a minimum, I'd like to work with them 6 visits, and I typically see them typically once a week. However, the biggest thing is developing a relationship with that patient on that first visit for them to understand and buy in that, therapy in the past may not have worked for you, but you need, at least these 6 visits to get you on the right path to have a successful surgery. Those individuals that I've been able to, that are willing to listen and, have that good buy-in, they have better outcomes. And I could have that conversation with those people that I do the preoperative evaluations. But when they come in and they only have 1 or 2 sessions and they say, that's it, that's all I'm going to do, it really makes it challenging on our part to really be thorough and to ensure that they're going to have a successful outcome. We lost them.
You're the host now, it says.
Interesting. There he is.
I think he's back.
Sorry for that. I think I have an unstable internet. But so what I heard last was that the 6th session is the optimum kind of setting to teach.
I'd say 6 to 8. Anything more than that for a patient that's been through, a history of chronic low back pain, they get a little burnt out on it typically. But if I could see, each of those individual 6 to 8 visits, I think that that makes a bigger difference.
Okay, well, then 6 to 8 it is. We start with 6 and then we extend it to whatever needed after that. Now, this patient now had the surgery. we are already half an hour into that, but maybe we can talk 5 minutes about after the surgery, you know, what are the, and you, as you know, when we do the surgery with the injury, there's lots of swelling there. In the hospital, we do 1 or 2 sessions of physical therapy, mostly for education.
Yeah.
But then we give the patient a period of time for the swelling to go down.
Mm-hmm.
Because if you try to activate those muscles too soon, I literally poked in that muscle 20 times.
Mm-hmm.
So we want to give it a little time for the swelling to go down. And usually 2 weeks to 4 weeks is a good time frame for, depending on the kind of the surgery we do. At that time, the swelling is back down enough that the balance is in the favor of continuing physical therapy. Now, sometimes when we, you get the patient, you know, you can do nothing with them. You just, whatever they do is painful. Obviously, that's where the individuality of the surgery comes in, that that surgery that I do, that 5-level fusion, and I poke anywhere in the lumbar spine, the paraspinal muscle, to put my screws in and so on. The first visit that you do with the patient, what are your criteria to understand if that patient is ready or not? What is physically, what do you do with the patient to see if that patient is ready? And if that patient is not ready, how do you deal with that?
I mean, it first starts when the patient walks back to our room. It just observing their sit to stand in the waiting area and watching them walk back depends upon, you know, a big indicator too is that, are they using an assistive device? How much are they relying on that assistive device? If somebody can stand up without, you know, hardly any effort and walk back to our evaluation room, you know, without a wince on their face, we're going to get going, you know, safely, but get after it right away. Whereas if the individual is really struggling and has that high pain, then we are going to, you know, slowly, you know, progress them. I do typically get every patient in a supine position, and we work through their bed mobility that first session and just ensuring that they're being safe and making sure that they're doing it properly so they don't further irritate themselves by doing it quote unquote the wrong way. And then from there, we start with kind of the lowest level exercises if it's indicated and work our way up. We start with, you know, just those gluteal sets, squeezing their butt muscles and just see if they can even tolerate that. That's just the first indicator, and depending upon how they respond, that's going to greatly impact how I treat. Some individuals, I'm going to have them do, you know, whether they have their brace on or not, making sure that they can do the proper, you know, hip hinging without stressing that spine, you know, right away, because they can tolerate it. But obviously we're not overloading the spine right away because of those restrictions that are set, you know.
Now, let me ask you another question. If somebody comes in such pain that you cannot really do your usual exercises, you see, teaching and education is always helpful.
Yep.
What do you see the value of just doing range of motion with them?
100%.
Okay.
Yeah, definitely.
You got a desensitization, right? I mean, they're like you said, they've got postoperative edema, so that doesn't stay just encapsulated within the tissue structures that you were repairing yourself with the surgery. That spreads off into the sensory cutaneous structures as well. They're hypersensitive. So it's working with them on educating on that, but then also desensitizing that tissue. You can do some manual techniques to do that, you know, help guide out do a little light effleurage to help with the edema management itself. But yeah, you're absolutely right. Then moving to graded, we call it graded exposure, graded activity, where you're just progressively encouraging, you know, safe, healthy ranges of motion. Because if you don't, I really believe if you don't do it early enough in the postoperative plan of care, they're going to develop a lot of, number one, fear avoidance psychologically, but then they could end up developing a little fibrosis in some of that tissue as it's healing.
So I think, and this is the value. Are you able to see my screen?
Yes.
this is the true value of the range of motion, because some patient who understand nothing of that, they come and tell me, oh, he just took my arm or leg or this, and that just stretched me out. I can't do that at home, and so on and so forth. But there is a science behind that range of motion exercises, where truly a muscle that is so in pain that want to be in one situation, you stretch them out. And by doing that, the two activation mechanism, you're fine-tuning it. One is the muscle spindle, that it just used to, it starts shooting signal in a normal position. You want to overstretch that and literally make sure that they get used to fine-tune that. Like when you drive a car, every time you press the brake pedal, did you know that your brake fluid auto-tune itself and adjust to the thickness of your brake pads? Did you know that? The same here. Every time you use your muscle, it's fine-tune itself to the range of activities it's supposed to do. Now, if you're in pain and you are never stretching that muscle beyond certain point, it thinks that is only the range of motion it's going to see, and it's only unfortunately fine-tune itself to that little range of motion, whereas that's not healthy. You want them to be adjusting the activity, the reflex that ensues from stretching that, to a range of a motion that is physiologic. And the difference is if a regular walking going to put them in spasm or not. That is the actual result of that. If you put them in a certain range of motion, stretch those muscles, stretch the muscle spindle, they know that this is a normal range of motion. I do not have to have protective kind of reflexes within that range of motion, because that's what every reflex is, right? If you're moving the muscle too fast, too much, it wants to counteract the forces that causes that. Now, unfortunately, for somebody who has gone through the surgery, those pathways are activated with little to no kind of stress because the muscle is irritated. And the range of motion can help the patient to adjust that to a range of daily activity. Now, once you do that, obviously, you go beyond that, right? You exercise with them their daily activity. Now, Cole, if I may ask you, what are those basic daily activities that patient complain to you it's really hard for them to do after the surgery? And what do you do for them?
Well, I mean, most frequently is safely getting in and out of bed.
Transitions, okay.
So the transition training is a big thing. The dishes are a challenge, as they often, they position themselves in forward flexion in that lumbar spine through that process, and we train on making sure that we do that movement appropriately.
Literally activity, like actual daily activity that patient tell you it's hard for them to do after the surgery. What are those? I mean, we talked about putting, tying their shoes and so on, but what are individual activities that you frequently see to be difficult for post-operative patient?
So the first few weeks, that's definitely showering and bathing, and we need to educate them prior to the surgery in order for them to understand. I frequently educate individuals on getting a shower chair just for the first few weeks or until they can tolerate it. So that's a big one, the showering, and then I encourage them to start to do those tasks such as cooking, cleaning dishes, those sorts of things, just to try them right away. Everyone seems to have a little bit different response to each of those activities. Everyone is unique, but I touch on each and every one of those to try to have them complete them as proper as possible post-operatively.
To be clear, we ask them not to bathe after the surgery because we poke hole in their skin. Don't want them to get soaked. Shower is okay, as long as you don't scrub or manipulate the skin. But let's say I am going to get a surgery, and what are you going to tell me how I should take a shower, or what additional help what guidance can you give me to take a shower on your side? I have some advices on my side, like let the soap and water run off your skin. Don't scrub it. If the wound is open, cover it with a clear film of plastic so it doesn't get wet and so on. That is my side, the wound management. But on your side, what are the things I should do or not do?
So like I said, the majority of individuals, I educate them on one, getting, you said, a shower chair if they don't, because the standing for multiple, minutes might be, irritating for them. Depending on the individual too, I encourage them to
danger of fall. Don't forget the danger of fall.
Yes.
Yeah.
So I was gonna say, grab bars are a big one, and then depending upon the individual, I educate them on showering with a spouse or a caregiver nearby or with them the first few times, just to make sure that they're safe with their transitions. It's the biggest thing. So whether
but then you have to make sure their spouse or the significant
they're educated too,
because you don't want both of them fall and then you have to treat both of them.
Yep.
And then one of the, going on that note though, Doc, is it's even better though when they're there. Another additional benefit of having that spouse or caregiver is that they're hearing the same message, right? So that when things get tough and that patient is at home and they're struggling with pain and they feel like there's a lot of fear, there's a lot of doubt in what they can and should be doing. They have a spouse, they have that caregiver, whoever it is, that's right there in their ear telling them, yep, just remember what you're told. This is going to be fine. This is still going to be safe. We just got to trust the process and go through it. And the more they're able to incrementally do those things, the easier it gets over time. I think that's a huge value piece that sometimes gets lost in the whole puzzle.
And I'm sure you adjust that to their individual situation. Like if they don't have really a shower, they just have a tub, and the situation is different. They have to get over the threshold. Yeah. If they have like a step going to the shower, situation is different. If the shower cannot accommodate two people, situation is different. I'm sure you ask them, what is your individual situation, and adjust the training to their individual situation, because it doesn't help them. You tell them they should have somebody there to be with them, but their shower barely fits one, right?
Yeah.
So
definitely too. And there's individuals too. I mean, it's always individualized, but there's some people that we practice stairs heavily because they have to get down one flight of stairs to get in the walk-in shower in the basement, compared to they just have a tub on their main level. So we definitely, that's a biggest piece of question asking during those initial visits is, what is your home setup like, and how can we make things easier for you post-operatively? Because that's a pretty common one where they don't have or they have a high tub shower on the main level, but they have a walk-in in the basement. So we get them in the basement to do the walk-in shower.
So now I'm going to last talk about the subject that a little maybe embarrassing to the patient, but is a fact of life and is important for this patient. Nick, do you know what I'm going to talk about?
I got a couple guesses. I don't know.
What
go ahead.
Talk about?
I think, are you going to, well, you go ahead. I don't even want to say it.
Sex, talking about having sex after a spinal fusion. So, Cole, do your patient ever ask you, can I have sex? Is it safe to have sex? Do they ask you that?
It's infrequent, but it is discussed. And luck, I mean, I'm happy that we had this discussion 3 years ago now, because I feel more comfortable talking about it with them. So I educate them to kind of fall back on their restrictions, as in we got to avoid the bending, lifting, or twisting during those activities. And then it really comes down to patient comfortability and tolerance to that activity. It's my understanding as long as you're following by the protocol that's already heavily discussed during your, the start of your session, there's no contraindication to that activity as long as you're listening to your body as the patient.
As a matter of fact, sex is like almost high intensity training for our body. Our body needs that. It's good for our body. But what's the downside when you have a catecholamine release? It suppresses the pain, meaning you may be doing something that is actually causing some damage without you really feeling the pain, meaning you forget in the moment, you forget, and you do all those limitations that would be not good for your spine. And then later you have to pay the price. Now, putting some thoughts in it will help you. Like, what position are we going to use? How we are going to go about it? What are the things we have to pay attention to? And if it was a rule of thumb, I would tell to my patient, number one, be the passive partner in that. Number two, if it makes you sweat, maybe it's not the right time for that in the first month after the surgery. So these are the rule of thumb. But again, that is very different from individually. I think the most important thing here is that this is not taboo. We have to talk about it, and we have to prevent the damage that can happen if we do it the wrong way. And that patient should not feel embarrassed about that. We are professionals, and that's fact of life. Now, we are at 6:56. I'm sorry, 6:56, and let's come up with three of us, each of us coming for three messages to people who listen to this should take out of this. Why don't we start with you, Cole? If you had to give three messages to the patient or other people who listen to that, what would be your three take home for people who listen to this?
The biggest thing post-operatively is that pain is still normal. And just because, and with that, we can continue to move and work through, discomforts pre and post-operatively to improve your function and your baselines. You are, having a significant, like I said, tissue injury with this surgery. So we need to let them know that. Two, that it's okay to move. We need you to move. If we do not move, we don't do your exercises, we don't start with a walking program, something of those sorts, we're going to be, missing our full potential in this recovery. And lastly, if you're a therapist consistently working with individuals that are having, a lumbar fusion, wow, it's a wide variety of, it's such a spectrum, and visit to visit with the same individual. And lastly, you could be working with a very fit and active 40-year-old individual that they want to get back to doing CrossFit, or you could be working with another individual that they literally can't stand for more than 30 seconds. So you really have to temper and individualize your programming, especially with this population, because we can't underdose these individuals, because if we do, we're doing them a disservice. So I guess the last thing is, don't underdose them. It's not good.
Nick, what's your three take-home message?
Well, I think the main one that I'm just gonna implore people to do is kind of piggybacking off what Cole just said, that they might have some preconceived notions on preoperative therapy, but just like we see with highly trained athletes who sustain serious injuries, serious traumatic connective tissue injuries, their recovery is quicker because their baseline again is much higher, right? So you have a unique opportunity when you can get ahead of your surgery and really train your body to be as adapted as it possibly can to recover and be in a position of good healing. I think that's key. Number two, piggybacking off that, strengthen the surrounding musculature. They have a tendency to become very myopic in what they view their injury to be, and that's like, this is my spine. My spine was injured, so that's where all their focus tends to go. But you can have a great deal of benefit, particularly training the lower body to be equipped with handling transfers much better. And then maybe number three is that as therapists, if there's therapists listening out there, you're watching, you got to be creative with what you're doing and listen to your patients, really probe and find out what are the issues that are really bringing them in. you said we gotta approach some things, even if they're taboo, right? But dissecting, getting into the weeds with your patient, at least for a visit or two, to find out, okay, what really are your struggles? Not just being like, how are you doing today? Oh, I'm okay, or I'm doing, but rather be more probing. Like I always use the example: get out to the vehicle with somebody. Actually, go out there and say, well, I want to watch you get in and out of your vehicle, because that could tell you a ton. That could tell you immensely more than anything you're going to get with them sitting on the table with you and then doing some table exercises. That would be my main message.
Do you have a car mock-up that you let the patient sit and get in and out?
No, I actually take them out to their own vehicle.
Good, even better. Yeah. Now, my take home is, number one, I get lots of patients who tell me, when I tell them I want to send them to physical therapy, they tell me, oh, they have a physical job or they are physically active. And my take home in number one is that is not equal to getting physical therapy. Mm-hmm. Physical therapy is a science.
Yeah.
If that was as easy as being physically active or watching some pictures and doing them, you guys wouldn't go 4 years to school to learn that. So it's not physically being active or have a physical job is not equal to physical therapy, number one. Number two, every surgery is an injury, meaning by any injury, the tissue get in that area to repair the process, start the repair process, and that causes swelling. The maximum swelling of a surgery is usually between the day 3 and 4. So around that time after the surgery, pain is normal. It is normal to have worsening pain. There's nothing wrong. It's just how our body heals. And my third take-home message is that if you are going to, after the surgery, this patient asked me a lot of questions about what can I do? How much of this or that can I do? There are certain limitations we give them in a written form, not like no bending, twisting, lifting. Anything beyond that, the best way to deal with that is doing a little of it in a controlled environment, best even first in your office, with you being present. First of all, seeing if they do it, they activate the right muscle or wrong muscle, do it the right way or wrong way. And then doing a little of it, watching it for a few days to see if there is any after effect. Like I had a patient often had severe pain like Fridays by the weekend. And we figured out Wednesday, she always do gardening. And then the effect always 2 days later, it's that she has horrible weekends. So meaning that watch what you are doing, keep a log book about what you are doing. If you are doing something new, do it a little, watch yourself for a few days. If your body agrees to that, do a little more and a little more and increase that activity little by little rather than going from nothing to go to full gardening or to full this and that. And that is more important than anything I would say about if something is right thing to do or not. In reality, I cannot go to people's home to see how they are doing things, to be able to say if that's right thing or wrong thing. The closest thing I can do is to send the patient to you, so you guys can watch them and give them advice in that regard. So that is my 3 take home. Now it is after 7. Thank you guys. This has been really great.
Yeah.
Well, thank you.
Educational channel as well. You may know we have a podcast now, and I'm going to put this on our podcast. Tens of thousands of people watch our podcast, so this will be added to our podcast for other people as well benefit from that. But thank you guys. It has been great talking to you both. Okay.
Thank you, Dr. Abbasi. We appreciate it.
Okay. Bye-bye.
Bye.